minutes or so on the basics of corneal and corneoscleral tear repairs here in open globe injuries, as the theme of the session rightly is here. So when you look at open globe injuries, the first thing when you're sitting there in the casualty or as a surgeon going to deal with them, you'll have to look at how you would grade the morbidity of the injury and what's probably going to be the prognosis. So prognosticating the extent of injury is what is going to be important. It's usually done on these lines, assessing or coming to a conclusion what's the type of the injury, looking at the amount of visual acuity diminution that it has caused, the pupillary, if you can assess the pupil in these injuries, and then classifying it into the zone of injury as zone 1 and 2. I think most of these are there in your textbooks. I don't need to delve into this, but then it's nice when you're, as a first-time physician surgeon, sitting there learning to evaluate and grade it and record it, and this is also good for medical legal purposes, primarily when you're dealing with trauma here. So that's one important aspect when you are looking into the basics of examination in a case of trauma here. So the nature of injury, the severity of the injury, a thorough examination including the pupillary involvement, which is also going to, by and large, several times you would not be able to assess the posterior segment. So your examination is going to be an indirect way of assessing how much of the posterior segment is also probably involved here, and you look at the anatomical extent. So in short, you're going to look at the anatomical severity and the functional severity that this particular injury has caused in the patient. What several times is forgotten is that you will also look at the systemic comorbidities which are existing in the particular patient here, because a grave injury, for example, as a road traffic accident, can have other significant systemic morbidities here, which is probably going to hamper the involvement or taking up the patient for a general anesthesia. So you would probably need supportive therapy for these. You would probably need to evaluate the patient. Most commonly, it's the neurosurgeon, the neurology, and the ENT specialties, apart from the appropriate investigations which are required for this, and also the anesthetic, a pre-anesthetic checkup to evaluate the fitness of the particular patient in the presence of such systemic comorbidities for taking him up for repair under general anesthesia. Always remember, open globe injuries are best done or always to be done under general anesthesia, even if they are small tears, because if there is a problem, if you take it up under a block, several times I do see people, if there is, the systemic does not permit an anesthesia, they tend to take it up under a block. But in an open globe injury, a block is going to be a grave risk for a retrobulbar hemorrhage. You will not be able to save a globe. So in an already complicated scenario with medical legal aspects sitting on top, I think it's not a wise decision. Always best done in under general anesthesia here. So quickly moving now on from preoperative evaluation on to what are the basics in corneal tear repairs here. So this is basically catering to most of the beginners here. What we need to understand, or what we probably read about as basics in suturing, corneal suturing, corneoscleral suturing, is that any suturing can lead to these particular 5 components of a suturing effect, which is the compression factor, the torque factor, the splinting, tissue eversion, tissue inversion. I'm not going to delve into the depths of this, but what is probably more appropriate in evaluating if your suturing is adequate in corneal and corneoscleral tear repairs is assessing the compression zone which will be involved for each suture here. So the length of the suture, which is taken as B, and the compression zone is the distance on either sides, which will be taken as B. This total one is the B. So what you'll always have to remember is the length of the suture, the A needs to be larger than the B, so that the length of the suture should be slightly larger, so that the compression zones of the adjoining sutures overlap each other, and this will prevent a wound leak, and this will make your apposition optimal. So this is the basics in doing corneal repairs or corneoscleral tear repairs, and much of it is quite explanatory with this diagram, and you could probably go back and revise more of it in detail in any of the standard standard textbooks here. Again, remember, when you're looking at large corneal tears like this here, you would probably place larger sutures. You would do the limbus apposition first. So that's going to be very, very important, and your limbal sutures need to be larger. And as you're going towards the center here, you would be putting smaller sutures. So once you are apposing the limbus, you're sort of trying at least maximal to sort of reconstruct the conical shape of the cornea and sort of restore is the initial tectonic, the initial shape factor of the cornea. So it's very imperative. So I've seen a lot of beginners trying to repair a suture with a central suture first. That's not a great idea. Always start with repairing the opposing the edges and then start on. So this is for a particularly a large corneal tear here, and you would always like to place your central sutures smaller. And remember again, the zone of compression should be overlapping for optimal effect. And the zone of compression is such that you do not got inversion or reversion or distortion or talking effect if you want to control the astigmatisms. Mind you, tears as large as this with a very good repair can give you a visual acuity of 618 or better. And if you can rehabilitate them with bringing them to 6.9 and 6.6 here with contact lenses later on. So the initial repair and your expertise in repairing these are going to go a long way in restoring or decreasing the morbidity of the particular injury which is there here. Again, just to touch upon the different types of tears which you have, what's commonly most difficult is stellate tears, like which you get as in this here. These are pretty simple tears, and if your iris has been out for more than 48 hours or so, then you would like to sort of excise the iris here. But if you feel it's a fresher injury and the component of infection is not there, then it's the decision of the surgeon to sort of reposit it back and see how much of anterior segment reconstruction can be done and take it up for a primary repair. Ideally, we do not advise a lens repair unless and until a lens management unless and until there's flocculent lens matter floating out in the AC with a rupture of the anterior capsule as well, because by and large getting your IOLs inside here with the correct IOL power is going to be a grave concern here. So you always would probably want to do it as a secondary procedure here. So getting back to stellate sutures here, you could just have mattress sutures here like in the center, or purse string sutures here, and opposing the other arms of a stellate suture with simple interrupted suture. So that could work well when you're going on as a beginner here. So quickly to run through a particular video. This was done by one of my senior residents here, because way back in our days when we did do repairs, we did not have much of recording facilities here. So quickly here, it's a very simple tear as you could see here, and always see that your chamber is well formed when you are starting these cases. Don't go in with a flat chamber, so go and take adequate care with forming your chamber there. And then you can see as you hear, she's placed the peripheral sutures here first, and then she's trying to reconstruct the apical shape factor of the cornea, trying to make it as near normal prolate as it is, and complete the surgery here. So this is a nice surgery here, which you could see that the peripheral sutures are all long and the central sutures are getting in, and the AC is well formed here. The compression zones are all overlapping each other. Check for a wound leak at the end of the surgery in these cases here. And when when they happen to be pediatric cases, you'll have to see that there was no iatrogenic factor, which would probably need the patient to be taken back up for another repair or an AC reformation. In the event that certain kind of injuries, if they are very perpendicular and they are leaking, you could always have your staff or your inventory to stock glue and bandage contact lenses as well. And this will really help if you feel you're not able to get a watertight closure in several cases as well, and in difficult cases. Yeah. I'll just move on to the next one. Most of the protocols I think we all know here. So the important things you would pay attention to is your suture management in the intraoperative phase. You would look at the associated ocular comorbidities which need to be managed either in the primary stage itself or which can be managed subsequently. The need for assessing this also lies largely because you need to counsel and talk to the family of the person who's undergone injury, because they are always going to expect they're going to get good vision here. So prognosticating and explaining the extent of injury and the need for subsequent procedures needs to be tackled when you take up such trauma cases here. And again, a good examination is also going to help you in assessing the need for additional devices during your primary or secondary surgeries, as was shown nicely by Rajesh earlier. Capsular retractors, capsular endocapsular rings, iris segments, aniridia, IOLs, iris implants, they all probably have a place in management of such scenarios, depending upon the gravidity of the situation which warrants their use here. Traumatic glaucoma is always going to be a concern. Management of astigmatism and subsequent need for contact lenses is again going to be a feature in these. Postoperatively, we always put them on antibiotics in the initial 24 to 48 hours, ensure that there's no infection here, and subsequently add on a steroid here. Other associative systemic and ocular supportive therapy is also going to be required. Also remember, you'll probably need to take some of your patients who are heavily psychologically traumatized into psychological support and counseling here. And again, the importance of assessment of comorbidity here. Just a quick second video here, which I'll just run to you. You see this is a corneoscleral tear, which you have extent going into the sclera as well. So always remember, which I would have probably done it differently. I would have placed my limbal suture first here. And when I do my scleral components, I always would use a vehicle suture rather than using my nylon to appose and place the sutures here. So I would prefer to have done a limbal apposition with vehicle sutures, do the scleral component first, and then move into the corneal component and form the AC before starting all these procedures. Again, sometimes it's not going to be easy. It's nice to comment on videos, but when you actually sit there, you need to sit and assess and see and do what is best is going to work out to get a watertight closure in such difficult cases here. I think we've pretty much covered much of the basics here, and we'll be happy to take any questions. Thank you for your patient hearing.
Thank you, Dr. Vanathi, for covering up the topic so beautifully. So while our next speaker, Dr. Ashish, sets up his presentation, are there any questions from the audience for Dr. Vanathi?
I guess one thing which needs to be highlighted, which probably she was showing in the video and not talked about it, is the rotation of sutures. Some small tiny thing, but we sometimes tend to forget it, and that causes one hell of trouble.
That's pretty much, I think, we consider as basics, but as you rightly pointed out, beginners, you always remember, and I do see a lot of our cases which are referred from periphery, which come out to us as an apex center, that the sutures are not rotated, and the patient is very, very uncomfortable because of a not induced irritation which is there. Yeah.
And second, the handling of the edges of the corneas were not done in your. That also needs to be highlighted. Yes. Can you speak about it? Then for the newer.
I think a good wet lab training is going to be very important in handling corneal tissue. So as beginners, and because of the anxiety also, they tend to squeeze the tissue. Always remember, even a 1 mm or a 0.05 lost is about 1 mm lost on both sides. So that's going to decrease your ability to reconstruct the prolateness of the cornea in cases of trauma. So you do not want to afford or give any place for tissue compression here because of poor handling, because whatever said and done, probably there is going to be a small component of compression factor when you're putting in your sutures here. So as beginners, I also tend to see that their sutures tend to be tighter than that's required, because they always feel a tighter suture is probably going to hold better, and you would find multiple wrinkles here. Another particular problem in handling the edge of any ruptures is the edema which is associated with it, and two is when the wounds are more than 24 to 48 hours, there's necrosis which is associated with it. So these also need to be assessed, and if you have an associated necrosis, if you have a lot of cheese wiring, that's when you probably need to have your glue put in. And sometimes you might need, if there is a large amount of area of necrosis, you also need to have donor tissue with you to probably effect a good reconstruction. So that's a good point which you point. I would add it on to my presentation next time.
I would like you to comment one last thing about the deposition of the iris. The concepts which we studied in my PG days were different. Now they see the viability of the tissue and all those things. Can you throw some light on that?
So
when should you deposit and when should you cut?
I think we still go back to our basics, what was taught to us. Any injury which we commonly used to see is less than 6 hours or more than 6 hours. Ideally, several times by the time, even if they report early, it becomes almost close to 24 hours when we take it up. So we keep a 24 hours as a rough, 24 to 48 perhaps as a rough guideline. The nature of injury which caused, for example, it was a firecracker injury or a lot of mud particles sitting there, then you know the chance of infection is much higher. You also run a posterior segment ultrasound to see if there is a anterior vitreous debris suggestive of an early infection in the posterior segment as well here. And you also assess the amount of tissue damage, because the tissue which is an iris tissue sitting out there wedged between the corneal tissue and outside is probably not going to be as normal as it's going to be or as healthy as it's going to be if you're going to reposit all these. So looking at all these factors, the surgeon then needs to make a decision of excising the tissue here. So which means you pull it up a little more and give a margin of 0.5 to 1 on either sides, so that when you finish your cutting, the normal tissue retracts back and the infected tissue is not gone in here. But if you're doing a fresh tear and your iris is just sitting there and you do not have any necrosis or tissue damage which is present in these cases, then you cut flush with the trauma surface, what's known as the abscission here, and then you allow it to go in. Or you could just reposit in if it's a very small amount, it's a clean iris and it's a fresh injury. And watch these eyes closely for postoperative infection here. Infection is always an invariable component in management of open globe injuries.
One last question. Do you give intracameral antibiotic compulsorily after every case of penetrating
trauma?
injury? Of trauma.
Not after every case. When I do my tests, I usually do a very small diluted gentamicin wash on the surface first, and do them repeatedly, wash them out repeatedly here, and then manage iris tissue as it is required to be managed here. And in the event you feel there is an associated intracameral infection and an associated vitreal infection there, even with the earliest doubt, then we do give intravitreal antibiotics. Intracameral, we try to keep your cornea as healthy as possible here. So that's one factor here. And several times, if the intracameral antibiotic management is not done properly, you can add on to the endothelial morbidity as well.
Also, the aqueous transformation
Absolutely.
is so high that
Yes,
the antibiotic is
and
not going to stay.
you would anyway be putting them on a frequent dosing of topical fortified antibiotics for them, which is going to work equally well enough here.
I guess just one indication which I feel of intracameral antibiotics is if the trauma is there for more than 48 hours, the uveitic tissue is out for more than 48 hours.
When the component of infection warrants it, then definitely you find necrosis, you find a hypopyon sitting there, and your tissue is also gone necrotic here. We can see it when you're handling, and that's a scenario which you evidently would want to use an intracameral antibiotic.